This is the Times of India Health Plus podcast. It's where we explore specially curated conversations, wellness trends, and lifestyle tips from the TOI newsroom. Stay informed, stay healthy.
Hello and welcome. I'm your host Anuja Jaiswal. Today we are taking a closer look at how heart care is changing and what these advances mean for patients. Heart attacks are no longer just a disease of old age. More and more young adults are being diagnosed with heart disease, raising an important question. Are we missing the warning signs? Can a heart CT scan detect heart disease before symptoms appear? How is artificial intelligence changing heart diagnosis? Are stents always the right treatment? And most importantly, what can each of us do to keep our hearts healthy? To answer these questions, I am joined by Dr Ambuj Roy, Professor of Cardiology at AIIMS New Delhi. Dr. Roy, welcome to the podcast.
Thank you, Anuja. It's my pleasure to be here.
We hear a lot about heart CT scans these days. What exactly is a heart CT scan and how is it different from other heart tests?
So there are two types of heart CT scans. One is the simpler scan, which is just like an X-ray, a very quick test where you look at the calcium deposits in your heart. And this calcium deposit is a kind of a surrogate for presence of plaques or small buildup of blockages in your heart. But this does not tell you the extent of the blockage, where the blockages are, how critical they are. And sometimes even in the presence of significant blockages, this calcium may be absent, especially in the young. So what is the second kind of a heart CT scan is a heart CT angiography. That is where we look at a very detailed picture of all the blood vessels or the blood arteries of the heart, what the percentage of blockage is, how many arteries are involved, whether those blockages are vulnerable to heart attack. So it's an extremely powerful method of looking at the arteries of your heart. This was about a couple of decades earlier, could be done only through an invasive angiogram, which now the CT scan has replaced in large measure, especially in cases where we are doubtful of heart diseases. We go for a heart CT angiography rather than the invasive form of angiography, which is the traditional angiography.
So it is easy form as compared
to... It is much easier. It is a much quicker procedure. The other one requires cath labs. It's invasive. It requires a puncture of the artery. Well, here it's just like a routine CT scan which is done. So it's much easier and lesser risk to the patients.
Okay. So how has heart diagnosis changed over the past 2 to 3 decades? Like test ECG, as you said that, angiography and cardiac MRI. How do doctors decide which test a patient needs?
Yes, so this really depends on 2-3 things. First, what is the symptom? What is the suspicion of a heart disease? And then what the test will make an impact. Okay. So first of all, depending on what you're suspecting, the kind of heart disease you're suspecting, suppose you're suspecting an acute heart attack, then ECG is the go-to test. We must do a ECG immediately, look whether there is sudden changes in the ECG which suggest heart attack, and then we need to immediately intervene. But the ECG may not be so great a test in a routine setup. So if you're looking at investigating for somebody with breathlessness, for example, and you're suspecting valve disease or a heart muscle disease, then you would go to an echocardiogram, which tells you about the function of the heart in terms of its contractility, how the valves are there any blockage in the valve, or is there leakage in the valve. So echo is used primarily for that. And then, of course, CT angiogram, which we discussed, looks at the arteries supplying your heart. And MRI is a relatively new measure. It does all that echo does, but even better. It looks at, again, heart functions, valve functions. It can even tell whether, in some cases of infection, whether there is infiltration in the heart. So MRI is, again, another level of test which is now available.
So should I say MRI is better than echocardiogram?
In some manners, yes, but echocardiograms are much easier to do. MRIs require, much longer time and are more difficult. Fewer centers of MRI are there. So I don't think every time you would need an MRI, But when there is suspicion of something which is not being picked up in echo, we would then go to the
for
MRI.
MRI. Okay. And basically, radiation is one of the things which
Yeah.
always, people think about it. Is it true that, echocardiogram is safer than MRI?
Yeah, so MRI and echocardiogram, they are since based on electromagnetic resonance, and this is based on ultrasound, have no radiation. It's only the CT which has the radiation side effects on where you need to use radiation X-rays, and which can be harmful.
Okay. And sir, with the rising incidence of heart attacks among young adults, should everyone be screened with a heart CT scan? Well, means I want to know that who should and who shouldn't.
That's a very pertinent question. Heart CT scans, if you see, have now become part of so-called executive health checkups. There are experts who are advocating, since we are seeing increasingly heart attacks in young, that every Indian above 40 years of age should get a CT scan done. Well, I strongly disagree with this. One, why? Because it's not feasible. We have about 40 crore Indians above 40 years of age.
Yeah.
So logistically, resource and financially, that's not possible. Two, is it needed? No, it's not needed, because there are very nice studies internationally done which show that in patients with diabetes, if you screen everybody, irrespective of their symptoms, with a CT scan versus just treat with conventional risk factor management, there were no additional benefit of doing a heart CT angiography, right? You were picking up more blockages, but you were not preventing more heart attacks or deaths. So just conventional, diligent management of risk factor was as good as doing CT scan for everybody. Having said that, yes, if there is a chest pain and you're suspecting heart disease, not screening for heart disease, yes, in those cases, CT angiogram is a great test to go to. It can rule in or rule out heart disease. So if it rules in, you allay the fear of the individual. If it rules in, then you can further manage those plaques, blockages with preventive medicines. Some of them are blood thinners, some are cholesterol-lowering medicines, which can stabilize those blockages and prevent heart attacks. And a study done in Scotland clearly showed that in patients with chest pain, when you do a routine CT scan, they lead to better outcomes. Not because you're doing more stents and surgeries, but you're more diligently managing their risk factors, giving them more frequently and with more confidence, giving them heart attack preventing medicines like aspirin and statins.
Yeah.
So that's how it works. So I don't think we should screen all. There is no need for it. It only creates a lot of anxiety, and especially in a private health system, for-profit health system, it is many a time a gateway to unwarranted downstream tests, even procedures, even surgeries, which are clearly harmful. So we need to be careful when we advise screening for all. It leads to many unwarranted procedures.
So can you suggest in one line that who should opt heart CT?
I think anybody where there is a fair amount of suspicion of heart disease, like he's having chest pain frequently, or he's having chest pain at rest, or he's having chest pain on exertion, is where we have what we call an intermediate risk, a sufficient suspicion that he has some blockages, where we do. In people where we are very sure that it has a blockage, then we would probably not do a CT scan.
Okay.
Suppose he has a limiting angina, which means even on little bit of an exertion, he's having chest pain and we are suspecting, or he's having an acute heart attack. Then I would not go for a CT angiogram. I would straight away go for a invasive angiogram, because in an invasive angiogram, you not only get the diagnosis, but you can immediately treat it also with a stent and open the blockages.
Angioplasty.
So in intermediate risk where there is a suspicion of heart blockages, CT angiogram is a good test.
Okay. Sir, how has the age profile of heart patients changed during your years as a cardiologist? And are there more young patients today? If yes, what do you attribute it to?
Definitely, we are seeing heart attacks in young. Of course, one could be that more diagnostics are available and we are able to diagnose people. But I think there's more than that. And it is clearly attributable to the lifestyle changes that we are seeing.
Okay.
Right? We've moved very quickly in a couple of decades from being deprived of food to being food abundant, right?
Yeah.
From toiling in the fields to sitting in front of screens and gazing at screens for hours together. In fact, if I say our grandparents were worried whether there was enough to eat, and now we are worried that we are eating too much and moving too little.
Yeah.
So obviously things have changed. There is a constant stress in modern life. There is, air pollution, which contributes to heart diseases. It's a silent contributor to heart diseases. Our diets have changed dramatically. We are not having the traditional home diet, but there are increasingly people having, because of lack of time, having food ordered from Zomatos
from
and
Zomato,
Swiggies, which are most of the time not very healthy food. So these are the lifestyle changes. And of course, we have a lot of untreated risk factors, which is tobacco use is still quite prevalent.
Yeah.
We have a lot of people, almost 70 to 80% of our people are not adequately treated for high blood pressure, for example. Diabetes control is important, cholesterol control is important, and these are not at the optimum level. So all lifestyle and these biological factors are contributing to increased younger heart attacks that we're seeing.
Okay. And what are the major risk factors that increase a person's chances of having a heart attack?
Yeah, so it's all of which I said. So their bad lifestyle.
That's a very important.
Very important factor because it affects everybody.
Yeah.
Right? And then we don't screen for what we should screen. So we should not do more CT scans, but we should screen more for simple risk factors like 3 of them being diabetes, hypertension, and dyslipidemia. So if we do manage the lifestyles and these risk factors, we will not eliminate heart attacks, but we'll reduce the chance of having that by about 70 to 80%. So the prominent risk factors are, diet, tobacco, lack of physical activity, hypertension, diabetes, cholesterol. And then, of course, if you have a family history of what we call premature heart disease, so if your first degree relative, mother, father, brother, sister has had a heart attack or a stent or bypass at less than, say, 50 years of age or 60 years of age, then that makes you more prone to having heart disease. So such individuals have to be even more careful and manage their risks and lifestyle even more diligently.
Okay. And how is artificial intelligence, which we talk about a lot, changing the way heart disease is diagnosed?
Yeah, I think, artificial intelligence is here to stay. And now, in some areas, it's been proven to be extremely useful, which is diagnostics. We have now AI apps which diagnose heart attacks.
Apps?
Yeah, you can just feed in your ECG and they will tell you whether this is an acute heart attack or not.
Okay.
And some of them are doing better than usual physicians and as well as cardiologists.
Okay.
So it clearly democratizes. Doing ECGs, even if I tell you of India doing ECG is easy, but finding the right cardiologist to interpret it 24/7 is difficult. So in many ways, it will democratize the availability of skills to diagnose, interpret ECGs. Then again, for echocardiogram also, it has been shown that it can read an echocardiogram quite well, almost equivalent to a cardiac physician. So a technician can record your ECG, which is much easier. Can record your echocardiogram, and the AI can tell you how the heart function is. So similarly, reporting CT angiograms, it's very efficient. It can, be a good screening to help the radiologists, because as the volumes will increase, we will not have enough manpower to, for example, read all those angiograms. So it will be again a very good screening. So I think AI will be a good second pair of eyes, but it should not be the final voice.
Yeah, definitely. But obviously it is resolving two things, that manpower and obviously time taking things. So, and you said that, it's sometimes it better diagnose.
It is, yeah. It diagnoses as well as the best, and the best are not available everywhere. We have huge shortage of the skilled and trained physicians. So it will definitely be, a good assistant to them so that they can work more efficiently.
Right. So stents are often in the news with questions about whether they are overprescribed. And what's your view, and what new treatment options are changing heart care?
Yes, you're right. Stents are actually amazing, I would say, technological advance. They can be extremely life-saving, and they are life-saving in acute heart attack situations where we need to quickly do an angiogram, fix the blockage during a heart attack, and stent it. So there is no doubt about its use in acute heart attack situations. But yes, in chronic conditions where you have blockages and you have what we call stable heart disease, it's not an ongoing heart attack. There, the role of stents is limited. It should be done only when your medical therapy is not working enough and you have limiting angina. Where it has been by young enthusiastic cardiologists been overused.
Overused, yeah.
And that has kind of led to a bit of disrepute for the stents, to the extent that I can just tell you an example for this last 2 BVAC. A very senior scientist at a senior in a very reputed academic institute came to one of the very reputed private hospital with an acute heart attack.
Okay.
And he was obviously advised stents. And the distress level is so much that his pain kind of subsided with the initial first aid that he got, and he was not ready to believe that he needed a stent.
Okay.
So some over-utilization has also led to a lot of bad name for stents, and people are actually missing acute care where stents are absolutely mandatory. So we need to send out the message that stents are extremely useful when you are in a heart attack situation, and time is essence, and you need to get that procedure done immediately. So this gentleman waited for another 24 hours, then came to AIIMS, and then we had to treat him. But then already you've lost the critical window period of management. So yes, stents have developed some amount of disrepute, but they can be extremely life-saving in acute heart attack situations.
But don't you think that some doctors overprescribe this stent and it can be manageable in some or other way?
Yes, it will be. I mean, if we look at, as I said, stable heart disease patients, and there is multiple large trials which they have shown that every blockage need not be fixed, right? Or need not be operated. They clearly showed in people who had angina or stable heart disease, except for a very small subset of 5 to 10%, when you have the blockage in the critical stem of the artery. In everybody else, these 70-80% blockages could be as well managed with just medical therapy and risk factor management.
Really?
And the outcomes were similar to those. So they divided into 2 arms. One got conventional medicines, one got the intervention, which was surgery or stent. And both the outcomes were not different. So clearly in that large chronic heart disease subsets, you can manage easily with medical therapy first. And if it doesn't work, then you, as a second step, go to the intervention. But unfortunately, that doesn't happen many a time in a for-profit health system, because it's obviously far more beneficial to the whole system to do a procedure than just prescribe a few tablets. So
anything a patient can identify that whether it is required or not?
So if you're not in an acute situation, it's not an acute onset chest pain, right?
Yeah.
Most of the time you can take your time, get the angiogram done, take a informed decision on whether you want a stent or not. But again, I mean, this is what sometimes, even in acute situations, people then shy away from stents because they develop this distrust for the stents. Yeah. So in acute situations, where you have just had an heart attack, new onset heart attack, it is needed. But if it's a chronic condition, you've been kind of okay for last 2-3 months, you get an angiogram done, they're showing multiple blockages, you don't need to rush into a stent. You can take an informed decision.
Okay. So finally, what are your top 3 tips for keeping the heart healthy?
Yeah, so I would say, let's begin with the acute situation. If you have an acute heart attack, or you wouldn't know that, but if you develop symptoms which are suggestive, like a chest heaviness, a crushing pain, a choking sensation, which lasts for beyond 20-30 minutes, go to the emergency immediately. It could be a heart attack.
Okay.
Many a times it's diagnosed as gastritis, acidity, especially in India, and we miss a lot of heart attacks because of that. So the only test there that will work is ECG. if it is positive for an acute heart attack, we need to immediately go for an intervention, which could be a clot-busting drug, or it could be an angioplasty. So there we need to be aware, and the system also needs to be aware. And many states have now what we call a STEMI network. The moment any hospital picks up that, they are referred to a tertiary hospital which can manage further. So recognize your symptoms quickly, know your numbers, which means know your blood pressure, know your sugar levels, know your cholesterol levels, and try to meet targets. They're very easy. If your blood pressure should be definitely less than 140/90, preferably less than 130/85. Your sugar average 3 months should be less than 7, preferably less than 6.5, what we call HbA1c. And your LDL cholesterol, depending on the amount of risk you have, should preferably be less than 100. And if you already have heart disease, your bad cholesterol or LDL cholesterol should be less than 70. And the third is lifestyle. No tobacco, eat healthy, and exercise regularly.
Okay, if something happens at home, then what you suggest to the patient to do first aid kind of a thing and then reach the hospital? Sometimes it's very difficult to reach immediately to the hospital, or if someone not at home, then what will they do?
So what we call as a first aid for heart attack could be just popping an aspirin pill.
Okay.
325 milligrams of aspirin is a great first aid to do at home. It's widely available, easily available, and you should do that. It is a blood thinner, and it works as well. The extent of benefit is same as that you get from a clot-busting drug in trials. So aspirin is a great first, where you have suspicion that this might be a heart attack. It's relatively harmless.
Okay.
And you can do that. And sometimes if you have somebody in your house is taking statins, you should take about a good dose of statin, which is usually 40 milligrams of atorvastatin. That has also been shown to be a good first aid drug. But I think you must get an ECG done. We need blinkets of ECGs which can reach your houses at 7.
Yeah.
We don't need more and more fast food, junk food reaching your houses. We need emergencies reaching your houses quickly. So unfortunately, ECG is the only test. Even an expert cardiologist will not be able to tell you whether it's a heart attack or not unless he's aided by an ECG. So getting that in the first half an hour is extremely important. And if you diagnose heart attack within the first 1 and 2 hours, heart attacks will happen. But if you manage to diagnose and treat it, you can abort an heart attack. Means that you can open the arteries and make sure the damage that happens due to heart attack, which is loss of heart muscle, will not happen. And you will, even if you have an heart attack, subsequently live with a normal heart. Unfortunately, in India, most of the people who present with heart attacks come by 6 hours or 8 hours after the onset of the symptom. And there, even if you do everything, right, even if you do the best angioplasty, you lose heart muscle, and subsequently the person lives with a weak heart. So as I said, the emphasis should be on early pickup and early treatment of heart attack so that you can abort the consequences of an heart attack.
Thank you, Dr. Roy, for providing all the detailed information about diagnosis and giving tips to our listeners.
My pleasure. And as I said, I hope this reaches people and, we can treat more and more heart attacks and prevent more and more heart attacks.
Don't tune out yet. It's time for the Nutrition Power Tip of the Week from nutritionist Sangeeta Iyer.
Pair your protein intake with fiber and remember to be well hydrated. An adequate or a high protein diet works best when it's balanced with adequate fiber and hydration. Including a wide variety of vegetables, fruits, legumes alongside with protein supports better digestion and gut health, and it will also prevent bloating and constipation.
Thanks for tuning in to the Times of India Health Plus podcast. You can catch us on Spotify, Apple Podcasts, YouTube, or the TOI app. And if you have a health topic you'd like us to discuss, write to us at toihealth.plus@timesofindia.com. Stay healthy and see you next time.